So good day viewers. Today I am actually going to continue with the second part of the knee joint. So in the last lecture I have discussed about the nature of the knee joint, its articulating surfaces, its type, and the ligaments which are actually rendering support to the knee joint, and the functions of the knee joint. Most of the ligaments of the knee joint we have discussed. So in that I have again stressed the importance of the intracapsular extrasynovial structures. Now today in this lecture we are actually going to discuss about the bursae which is present around the joint, followed by the relations, blood supply, nerve supply, and very important, the movements of the knee joint, followed by the applied anatomy. Okay. Now coming to the bursae around the knee joint, there are a lot of bursa which is present around the knee joint. So we all know that around a knee joint there are bursa which is present because the muscles which are acting on the joint, the tendinous insertion, what happens is come very close to the bony surfaces, and because of that what happens is the tendon might actually cause a friction during any movement, and that might lead to damage to the tendon. That is one reason. The second reason is because of that what happens is then the movement will become painful, and what happens is there might be a restriction of the movement. So because of this what happens is you can see there are bursas which are disposed around the joint. In the same way the knee joint has also got bursa. I think it has the most number of bursas. So we will just quickly list out these bursas. First bursa is the prepatellar bursa, which you are able to see here. It is present subcutaneously between the skin and the anterior surface of the patella bone. Prepatellar bursa in front of the patella, that is why it is actually called as the prepatellar bursa. Now inflammation of the bursa is actually called as a housemaid's knee. You know why it is called as housemaid's knee? Because housemaids, they kneel down on the floor and they mop the floor. So more prone for the inflammation of this bursa in housemaids. So that is why it is called as housemaid's knee. Then you have one more bursa subcutaneously deep to the skin, which is again called as the infrapatellar bursa. So that is seen again between the skin and the tibial tuberosity. So where the your quadriceps tendon, ligamentum patellae, is going to get inserted. So there between the skin and the tibial tuberosity you have the infrapatellar bursa. So inflammation of this bursa is actually called as the clergyman's knee. So a clergyman is someone you can see in the churches who kneels down and prays for the others also. So if you have any wish or anything you need to pray, then in the church the clergyman, what happens, he actually prays for you. So that is called as clergyman's knee. So most prone for the inflammation of this bursa in clergymen, so that is why it is called as clergyman's knee. Subcutaneously you see two bursa. Then infrapatellar bursa, one more, it is also you have a deep infrapatellar bursa between the ligament and the upper end of tibia. Okay, between the upper end of tibia and the ligamentum patellae, you have the deep infrapatellar bursa. So related to the patella, you have prepatellar bursa and infrapatellar. One is subcutaneous and other one is the deep infrapatellar bursa. The other bursa, you can see there are laterally four bursas which are present. Before that, suprapatellar bursa. This is actually called as the suprapatellar bursa between the quadriceps tendon and the femur, and this bursa communicates with the joint cavity. You can see even the synovial just giving a pouch like extension into this suprapatellar bursa. Okay, so this bursa communicates with the joint cavity. Then we have four bursas laterally, mainly two bursas related to the tendon of popliteus, and one related to the lateral head of gastrocnemius, and one related to the fibular collateral ligament. Okay, so one is between the capsule of the joint and the lateral head of gastrocnemius, the other one between the fibular collateral ligament, and above that you will have the tendon of the biceps coming superficial to the fibular collateral ligament. Then between the popliteus and fibular collateral ligament, and between the lateral condyle of tibia and the popliteus, one more bursa. Okay, so mostly we come across four bursas laterally. In the same way, you also have four bursas medially. One is between the tibia and the medial head of gastrocnemius. Okay, so between the tibia and the medial head of gastrocnemius, you have one bursa. Then the other bursa will be between the deep part of the tibial collateral ligament and the medial condyle of tibia. Then this bursa we have already discussed, bursa anserina, which is present between the insertion of the gracilis, sartorius and semitendinosus. Okay, so between the medial head of gastrocnemius and the capsule, then bursa anserina you see on the medial side of the upper end of the tibia. Okay, between the gracilis, sartorius, semitendinosus, and then between the superficial and deep parts of the tibial collateral ligament, you have one bursa, as I told you, and the other one will be between the semimembranosus and the medial condyle of tibia. So laterally four bursa we have seen, medially four bursa we have seen, even anteriorly we have seen four bursa, one suprapatellar, one prepatellar, and two infrapatellar bursas. Nerve supply of the joint is mainly by the femoral nerve and the obturator nerve. The femoral nerve will give branches via the vastae muscles. So the muscular branches which is supplying the vastae, medialis, lateralis, intermedius, through them it gives an articular branch to the knee joint, the femoral nerve. Obturator nerve, posterior division, genicular branch, it will pierce the oblique popliteal ligament and then it will supply the knee joint. So that is through the obturator nerve, femoral nerve, obturator nerve. Tibial nerve also gives superior and inferior medial genicular branches. Tibial nerve will give superior and inferior medial and middle genicular branches. Even the common peroneal nerve will give superior and inferior lateral genicular and the recurrent genicular branches. Okay, so tibial nerve mainly the medial side, posterior medial side, and common peroneal nerve the lateral side of the joint. So mainly femoral nerve, obturator nerve, and the tibial and common peroneal nerves, they supply the knee joint. Coming to the blood supply, mainly the arterial supply, it is in the form of genicular anastomosis. It is actually in the form of genicular anastomosis. So if you look at the genicular anastomosis, mainly the branches are supromedial, infromedial, suprolateral and infrolateral branches from the tibial artery. Okay, so mainly the supromedial branches, they anastomose of the tibial artery, supromedial genicular branches with the descending genicular artery, and infromedial branches, they will actually anastomose with the tibial, posterior, anterior and posterior tibial recurrent arteries. Supralateral genicular branches will anastomose with the the lateral circumflex branch. So a descending branch from the lateral circumflex artery. Okay. Then inframedially it is from the circumflex fibular branches. Okay. So branches mainly superomedial, inframedial, superolateral, infralateral and middle genicular branches from the popliteal artery. From the popliteal artery, they anastomose medial side with the descending genicular branch of femoral. Okay, with the descending genicular branch of femoral, and then what happens with the anterior tibial arteries? Laterally with the lateral circumflex artery and circumflex fibular branch of the posterior tibial artery. So that is about the arterial anastomosis. Next, coming to the relations of the joint, in front mainly you are able to see it is related to the quadriceps tendon. Okay, and naturally this ligamentum patellae also gives an extension laterally which is called as the medial and lateral patellar retinaculum. Okay, so quadriceps tendon and medial and lateral patellar retinaculum, they form the anterior relation of the joint. Next, coming to the posterior relations, mainly posterior, you can see the popliteal fossa. So the structures, the contents and some of the boundaries, walls of the popliteal fossa mainly form the posterior relations for the joint. Okay, because you know that the floor of the popliteal fossa is mainly formed by the capsule of the knee joint, popliteal surface of femur, fascia covering the popliteus muscle. Okay, so contents, as I told you, posterior vessels, tibial nerve, gastrocnemius and the plantaris, they all form the posterior. And posteromedially you have these sartorius, gracilis semitendinosus. Posterolaterally you have mainly the tendon of biceps and common peroneal nerve. Okay, so this is actually the tendon of biceps and the common peroneal nerve, posterolateral relations. Posteromedially you will have the gyrobes, mainly the semitendinosus, gracilis and sartorius muscle. So if you look at the cross section of the knee joint, so you are able to see the knee joint, the menisci, you are able to see the medial meniscus and the lateral meniscus. So that is your quadriceps tendon, ligamentum patellae, bursa, prepatellar bursa, you are able to see here. This is the tibial collateral and that is the fibular collateral ligament. Popliteus tendon, which is inside the capsule but outside the synovial membrane. You are able to see the reflection of the synovial membrane in dotted lines. How they reflect? Along the periphery of the articular surfaces only they reflect, but they don't come inside. And the sides of the cruciate ligament they reflect, and you are able to see they are also forming a synovial fold. Okay, which is actually your primitive septum, as I told you in the last class. And then posteriorly you are able to see the gastrocnemius muscle and contents. You are able to see here popliteal vessels, tibial nerve, all those things you are able to see here. This is your oblique popliteal ligament, which is an extension from the semimembranosus. This is semitendinosus tendon. This is gracilis and sartorius. Posteromedially gracilis and sartorius. Posterolaterally you see the biceps femoris tendon, and more posteriorly you see the walls of the popliteal fossa and contents of the popliteal fossa. Anteriorly the ligamentum patellae and quadriceps tendon. So this will give a very fair idea about the relations of the knee joint. So next, the very important aspect of the knee joint is the movements of the knee joint. So you all know that the main movement which is taking place in the knee joint is the flexion and extension. Okay. Now how actually this flexion and extension takes place around a transverse axis, and medial and lateral rotation takes place in a flexed knee, semi-flexed knee or flexed knee. Medial and lateral rotation, independent or adjunct rotation takes place, but conjunct rotation takes place during the beginning of flexion and at the later stages or the end of extension. So the axis is a transverse axis, and the axis keeps on shifting upwards or anteriorly during extension and backwards or posteriorly during flexion. As I told you, if you look at lateral profile of the joint, it has got numerous circles, arc of a circle, and if you join a point on the center of all these circles, then you get a curved line which is actually called as the evolute of profile. So through this center of each circle, what happens is the axis keeps on shifting during each stage of extension and during each stage of flexion. And when the knee is extended, what happens is there is maximum congruency. There is maximum congruency. Hyperextension, to some extent it is possible, which is only 10 degrees. Hyperextension is only 10 degrees. Okay. And the center of gravity usually passes slightly in front to the center of the knee joint. Okay, it is not exactly passing through the center of knee joint, it is slightly passing to the front. So what happens is, naturally there should be a tendency for the knee joint to be pushed or dislocated forward or hyperextension, and that is why it is always arrested or checked by the antagonistic muscles. So that is the muscles apart from the extension, the antagonistic muscles, they always check the hyperextension of the knee joint, and also by the ligaments which becomes taut. Okay. So as I told you, the medial or lateral rotation might be conjunct with, associated with the flexion and extension, or you might have independent or adjunct rotation during a flexed knee. Medial and lateral rotation is more pronounced in a flexed knee. Okay. So as I told you, this conjunct rotation takes place in the lateral stages of extension or during the beginning stages of flexion. So locking is a very passive mechanism. Now what happens is, when the knee is locked, there is maximum congruency, maximum contact between the femoral and the tibial condyles. And when the extension is complete, the tibial collateral ligament, the fibular collateral ligament, the anterior cruciate ligament, oblique popliteal ligament, all the ligaments are actually taut except the ligamentum patellae. The ligamentum patellae actually is freed and relaxed because the quadriceps are relaxed during standing, and patella can be moved freely. There is no contact of patella with the femur, and the quadriceps are relaxed. Now this extension you can see during your normal or symmetrical walking. This is the position. During asymmetrical walking, for example, if you are walking on a rough surface, if it is not a flat surface, or you are walking with one leg up and down, or when you are standing with one leg at a lower or higher surface, then you can see your knee is extended completely, and then you can see the tension of the quadriceps muscle. So to short periods of time, the quadriceps is actually contracted and you get maximum extension when you are walking on an uneven surface or when the walking is not even. Okay, so only then quadriceps come into play during the extension. So that is what I told you, active contraction during asymmetrical walking or during powerful thrust, when you want to thrust forward against any resistance. Now coming to the locking mechanism of the knee joint, how actually takes place. Now let us assume first that the femur is or the knee joint is completely flexed. Now from the flexed position, what happens is the knee has to come to the extended position. From the flexed to the extended position, what happens is rolling and sliding movement takes place. Now first what happens, the femur slides over the tibia. Once the femur slides over the tibia forwards, when there is a sliding of femur over the tibia forwards, then naturally what happens is your oblique popliteal ligament, your posterior cruciate ligament will get stretched. Then what happens is this sliding is actually taking place around a transverse axis which is running from the across the condyles, and as I told you, the evolute of profile, all those things. Now once this ligament is taut, then the femur spins forward. Okay, so what happens is there is the femur which is spinning forward again around a transverse axis. Now because of this lateral condyle is smaller and stouter, it reaches the anterior horn of the lateral meniscus more earlier than the medial meniscus has reached. So it has got a smaller articular surface antero-posteriorly. Now what happens is, for the lateral condyle and the lateral meniscus is completely used up, but the medial condyle is not used up. At this stage what happens is the anterior cruciate ligament becomes taut. Okay, the anterior cruciate ligament will become taut, and around this, serving as the vertical axis, the femur rotates. Okay, so now what happens is the femur rotates medially. So that means the lateral condyle will actually rotate medially. Vertical axis passing through the anterior cruciate ligament, or some books describe it as the lateral condyle. The lateral condyle, when it rotates medially, so naturally the medial condyle also moves medially, thereby now the medial condyle is completely used up. Okay, so now what happens is, that is what the steps I have already told you. Anterior cruciate ligament is taut, extension at lateral condyle is arrested because it is completely used up. Now passively the medial condyle, rotation of lateral condyle around the anterior cruciate ligament serving as the axis takes place. So this medial condyle now glides backwards. Actually what happens is, even the lateral condyle is actually gliding. Now the gliding movement takes place, and now all the ligaments are taut and complete extension is achieved. So now its full extent, screw home or lock movement. It is actually called as the locking mechanism or the screw home movement. So in a screw home movement, the joint is safe. So I will tell you main things again, repeat during the locking mechanism. Since the lateral condyle is shorter and stout, the antero-posterior length is smaller. It is completely used up before the medial condyle reaches its maximum congruency. Now, the lateral condyle is arrested, anterior cruciate ligament becomes taut or tight, you can tell it. Serving the anterior cruciate ligament as the axis, vertical axis, the femur will rotate passively. Medial rotation takes place. So, lateral condyle slowly glides forwards, and medial condyle, what happens is, medial glides slowly backwards. Now all the ligaments become tight. Your tibial collateral, fibular collateral, posterior and anterior cruciate ligament, and maximum congruency and full extension is achieved. Okay, so this shows about the antero-posterior translation. Okay, so and then medial and lateral abduction and adduction, you can see here what happens, and the lateral rotation and medial rotation, how actually it takes place. Now, unlocking movement is by the lateral rotation of femur. Now, the medially rotated femur, what happens is, it has to laterally rotate. So that means something has to pull the lateral condyle laterally backwards. Now the lateral condyle has moved forwards, medial condyle has glided backwards during the locking mechanism. Now during the unlocking mechanism, same way with the anterior cruciate ligament being the axis, the lateral condyle has to glide backwards, and that is called as the unlocking movement, and that is facilitated by the popliteus muscle. So the popliteus muscle initiates the flexion or the unlocking movement of the knee joint. Now the side ligaments, that is the fibular and the tibial collateral ligaments, are relaxed. Okay, so the cruciate and the anterior part of tibial collateral ligament are taut or tight at this time. So you are able to see this tendon of popliteus, when they contract, it will pull the lateral condyle backwards. So naturally what happens is, unlocking movement takes place by the lateral rotation of the femur. The popliteus also serves one function. During this, it also pulls the lateral meniscus backwards. It also pulls the lateral, so that the lateral meniscus does not get pinched between the articular surfaces. That is one thing. So the last stage of the extension and the initial stages of flexion is taking place around the medial meniscus, because this is arrested before itself. That is why there is lot of wear and tear in the anterior horn of medial meniscus, and the anterior horn of medial meniscus is somewhat narrower as compared to the anterior horn of lateral meniscus. Okay, so if you look in any movement of the knee joint, whether it is the flexion or the extension, one of the cruciate is always taut, and mostly the anterior cruciate ligament. Now, in a flexed knee, if the knee joint is flexed, independent rotation takes place. Not only that, I told you there is medial rotation of the tibia during the later stages of extension, and lateral medial rotation of femur in the lateral stages of extension, and lateral rotation of femur in the beginning of flexion. Vice versa, what happens is, there is actually lateral rotation of tibia during extension, and medial rotation of tibia during flexion. So this happens in a semi-flexed knee. This happens in a semi-flexed knee. Okay. Not only that, the range of flexion is actually 120 degrees. The range of flexion is actually 120 degrees, and which can be extended up to 140. 160 degrees is when your calf region touches your thigh, when you completely bend. So maximum is 160 degrees. Okay. Now mainly extension, as you all know, it is mainly by the quadriceps, and when the quadriceps comes into action during your uneven walking, then other extensors, tensor fascia lata helps to keep the knee in extended position. So laterally it gives support to the joint. Flexion, semimembranosus, semitendinosus, biceps and hamstring part of adductor magnus, but initiated by the popliteus muscle. You all know that unlocking movement is mainly produced by the popliteus muscle. Medial rotation is by the gracilis, semitendinosus and semimembranosus. And lateral rotation is by the biceps femoris muscle. So these are the muscles producing the movement. So the locking and unlocking movement of the knee joint can be asked separately. So you should explain the sequence of events of this locking and unlocking. Coming to the applied anatomy, you are able to see two conditions mainly. One is actually called as the genu valgum or the knock knee, and genu varum or the bow knee. So what happens in case of the genu valgum is there is an exaggerated inward angulation and there is associated eversion deformity. Okay, so eversion is also not possible. This is actually called as the genu valgum. So genu valgum might occur due to any bone diseases like rickets, or it might be due to idiopathic reasons or nutritional or congenital. Sometimes it might run within the family, it might also be congenital, inborn. The next type you are able to see here is the genu varum, which is actually called as the bony increased or exaggerated outward angulation, and you have deformity with inversion. Okay, so inward deformity or inversion deformity of the foot takes place. Now when you look at the genu varum in children between 3 to 4 years, you can see there is slight amount of this genu varum and the sole of the foot faces inwards. This is common, and as the child grows, what happens is this disappears. In 3 to 4 years children and in infants, you can see that once when they start walking and all, this genu varum will be there, but as the ossification is complete and the menisci completely grows, then naturally the genu varum, what happens, disappears. But if at all it is present at later stages, then it is actually a deformity of the knee. Again, this might also be due to nutritional deficiencies or rickets. The conditions which I have mentioned for the genu valgum also applies for the genu varum. So here you are able to see a radiograph of the knee. One is the normal radiograph. You are able to see the medial condyle, the lateral condyle of the femur. This is the tibia, intercondylar crust and intercondylar area. This is the shadow of the patella you are able to see here, and here you are able to see the fibula. This is actually a arthritic knee, especially the arthritic knee joint. So the main thing what you are able to see here is the joint space is reduced. You are able to see the joint space is actually being reduced. Then you are able to see degenerative changes, arthritic changes. You are able to see in the knee, bone erosion is taking place. Okay, there is also erosion of the bone. So these are the two classical features which you come across in an arthritic knee. So it might be due to so many reasons. Osteoarthritis is most commonly and age related. Other types also affect the knee joint, like your rheumatoid arthritis affects the knee joint. So osteoarthritis of knee, in very severe cases of the arthritis of the knee where no movement is possible, then what happens, what is suggested is total knee replacement. You are able to see the prosthesis, the femoral prosthesis and the tibial prosthesis are actually screwed to the lower end of the tibia, and the upper end of femur is replaced by prosthesis. Naturally, what happens is total knee replacement. To some extent, what happens, it provides some relief to the patients, some movements is possible. Okay. So, you are able to see the affected knee side. It is swollen, mainly joint effusion. You are able to see swelling and a pain over the knee region is actually called as knee joint effusion, and the patella floats over the femur. Simple knee joint effusion might also be due to inflammation of the bursa. The other reasons where the knee joint effusion takes place: dislocation of the knee joint, ligament tears or meniscal tear. Any of the ligament is injured, especially your tibial and fibular collateral ligament, or if your menisci is injured, then also it leads to knee joint effusion. So knee becomes stiff and the mobility is reduced. So you won't be able to move the knee joint. There is reduced mobility. So mainly any direct trauma to the knee. Now, for example, if there is a direct trauma to the outside of the knee, then your fibular collateral ligament will actually get injured. If the knee is pushed outwards, your tibial collateral ligament is injured. If there is a direct injury to the medial component of your knee, then your fibular collateral ligament will get injured. Okay. Any sudden hyperextension or twisting of the knee leads to dislocation or tear of anterior cruciate ligament, and also leads to meniscal tear. So most commonly anterior cruciate ligament and meniscal tear is common in sports, especially in your football, soccer, basketball. In all those sports, what happens is there might be ACL tear, anterior cruciate ligament tear, and also meniscal tear, mainly due to violent abduction with lateral rotation in a flexed knee. So most commonly injured is your anterior cruciate, then you have the meniscal tear, and then you see the tibial collateral ligament. So when these three are injured, it is actually called as the unhappy triad of odontology. Okay, it is actually called as the unhappy triad. Injury to the anterior cruciate, medial meniscus, and the tibial collateral ligament. So if there is meniscal tear and cruciate ligament tear, then naturally what happens is you will hear a popping sound during the extension of the knee, difficulty in movements. In meniscal tear, you will feel pain when you medially rotate the knee. During medial rotation of the knee, you feel pain. Meniscal tears, again, what happens about the meniscal tears? It might be a longitudinal tear, or you can see a radial or an oblique tear. The longitudinal tear is actually called as the bucket handle tear. Sometimes the peripheral part of the menisci, what happens is it avulsed. Okay. So most commonly injured is the medial meniscus, because the lateral meniscus is pulled by the popliteus muscle so that it doesn't get pinched between the articular surfaces, and more amount of movement or action is taking place around the anterior horn. As I told you, it is used up during initial stages of flexion and later stages of extension. So the medial meniscus is most commonly injured. Okay, so commonly deranged along with the tibial collateral ligament. So meniscal tear, what happens is sometimes rest, it might heal, or otherwise if it is torn extensively, total removal of meniscus is advised surgically and the menisci regrows. Okay, so as I told you, these are all about the tear longitudinal wedge shaped and held between the articular surface of knee in flexed position. ACL tears, when there is an anterior cruciate ligament, usually most commonly involved, both the two is the ACL which is involved. Any anterior-posterior movement, abnormal anterior-posterior movement of tibia shows positive drawer sign which indicates an ACL tear. Okay, so increased gliding of tibia over the femur. If the tibia is somewhat abnormally mobile, front or back, then it indicates that there is an injury to the anterior cruciate ligament. Most commonly anterior cruciate ligament, but very rarely the posterior cruciate ligament actually is injured. Okay, so as I told you, the anterior cruciate ligament is the most commonly injured. So unhappy triad is injury to the medial meniscus, anterior cruciate and tibial collateral ligament. Drawer sign is ACL tear, anterior cruciate ligament is there, then there will be increased mobility, anterior-posterior mobility of the tibia, which is actually called as the positive drawer's sign. So that is mainly about the applied anatomy of the knee joint. So this is arthroscopy of the knee. So viewing of the interior of the joint, you are able to see femur and the tibia covered with the hyaline cartilage, articular cartilage. The menisci, you are able to see a tear in the meniscus. The most commonly it is the medial meniscus. Mainly medial or lateral antero-posterior mobility. Sometimes when you suddenly get up from the chair also, abnormal any awkward posture might also lead to tear of this meniscus. Then fracture of the patella. So patella is not commonly fractured, and when actually it fractures is when one leg is slips to prevent you from falling, the other leg which is actually supported on the ground suddenly is extended, and naturally what happens is patella fractures on that leg which is fixed to the ground. So sudden extension, what happens is pulls the quadricep tendon and the patella fractures transversely with an upper segment and a lower segment. The lower segment, fractured segment will be small and the upper segment will be large. And patella, what happens is it does not fuse because there is no periosteum for it to fuse. Okay. So arthroscopy of the knee mainly to diagnose any meniscal tear or ACL tear. It is very, very useful. So that is all for to this lecture, and we have completed with the knee joint. Thank you very much for your patient listening.